Okay, great. Okay, welcome to the Good Hormone Health webinar, November 7th, 2021. I'm very happy to host Dr. Tobias Carlin. Dr. Carlin is the director of the Adrenal Center in Tampa, and I'll show his credentials on the next 2 slides. His talk today is an amazing talk. It's a 20-minute mini back scope adrenalectomy. And I want to just go over the reason for adrenal surgery. The most commonly for our patients here is bilateral adrenalectomy for pituitary or ectopic Cushing's. This is ACTH dependent. If you have a low ACTH, you have adrenal Cushing's. If you have medium to highish ACTH, you have pituitary Cushing's. And if you have quite high ACTH, you have ectopic Cushing's. And we usually treat pituitary Cushing's with pituitary surgery or medications. And people know I use a lot of the medicine ketoconazole. But there are plenty of patients that break through the medicines or they don't work. They are not a candidate for pituitary surgery. So these are the people that would be a candidate for, as we call them in the chats, BLA or bilateral adrenalectomy. The second issue I put here, a reason for adrenal surgery, is unfortunately common. I shared my article with Dr. Carlin. His comment was, unfortunately, some of the adrenal surgeons aren't that good, and they leave behind or remnant tissue develops. And I have a series of about 11 patients with adrenal remnant tissue. These are very difficult to find the adrenal tissue and to remove it. And Dr. Carlin is an expert at reviewing the CAT scans and looking for this adrenal remnant tissue. So this would be another indication for adrenal surgery. There are patients, and it's, at least in the literature, it's quite common, although I have a little less of these patients, that have adrenal Cushing's. This is ACTH independent. You have a low ACTH. You have one nodule on an adrenal, or often or sometimes multiple nodules on one adrenal, and you would get a unilateral adrenalectomy. There are patients that have what's called an aldosteronoma. They have high aldosterone levels and low renin levels. Biochemical testing confirms that it's an aldosteronoma and not this bilateral aldosterone hyperplasia. These are good candidates for unilateral adrenalectomy. And then the patients with pheochromocytoma, which I see very little of, they would be a candidate for mostly a unilateral adrenalectomy and occasionally a bilateral adrenalectomy. Okay, I'm going to hand this over to Dr. Carlin, but I'll do the slides. Dr. Carlin is Surgeon-in-Chief and founder of the Carlin Adrenal Center, the Hospital for Endocrine Surgery in beautiful Tampa, Florida. His website is adrenal.com. Go ahead, Dr. Carlin.
Thank you very much, Dr. Friedman. It's a great honor and privilege to be talking to you all about my favorite topic, which is adrenal surgery and adrenal disease. And as Dr. Friedman told, we have significant experience with adrenal surgery in all those settings as he described, as well as an area that's actually increasing for us. And I'm not going to talk too much, but in adrenal metastasis from other primary malignancies where the patient has an isolated metastasis. Mm-hmm. So we can jump to the next slide. So as Dr. Friedman mentioned, I'm in Tampa, Florida. Just to give you a brief background, and if you're wondering where my accent is from, I'm originally from Sweden. I did my MD PhD at Uppsala University in Sweden, and long story short, a story involves my now wife. We've been together almost 21 years, but long story short, spent some time in San Diego. We met, plans changed because I was going to join the endocrine surgery team in Uppsala, which is one of the premier endocrine surgery practices in Europe. I ended up at Yale and was at Yale University for almost 20 years and was the chief of endocrine surgery. But the opportunity to move to Tampa to create something truly unique with our own hospital. I was probably the busiest adrenal surgeon in the country at Yale, but it was still frustrating in the sense that I could only reach a very small percentage of patients because, as I'm sure you all know, adrenal diseases, adrenal tumor diseases are highly underdiagnosed and undertreated, whether it's subclinical Cushing syndrome, overt Cushing syndrome, hyperaldosteronism, or pheochromocytoma. So we really set out to revolutionize the knowledge of adrenal tumor disease through adrenal.com. And despite COVID, I'm happy to report that we're by far the busiest adrenal surgery practice in the country. We're doing up to 6 to 8 operations in a single day.
Wow.
So this Christmas and New Year's, we're moving into the brand new hospital. So this is a hospital, the first of its kind, exclusively focused on endocrine tumor disease. So it's only adrenal, parathyroid, and thyroid. So it's a full-fledged hospital with 8 operating rooms, of freestanding emergency room, and inpatient beds, and that's where all patients with adrenal surgery is going to be hosted. And my practice is such that about 7-8% of patients come from outside the state of Florida. So it's conveniently located very close to the airport, about 10 minutes from Tampa International Airport. Next slide, please. So as I mentioned, all 4 groups, the scarless thyroid surgery practice, the thyroid center practice, and the parathyroid practice, and then the Carlin Adrenal Center are all host in this unique hospital. Next slide, please. So why focus on adrenal surgery? Well, as I will talk a little bit, I had a strong scientific interest in adrenal tumor disease, and I'll present some of our original scientific work on both cortisol producing tumors and aldosterone producing tumors. But adrenal surgery is an adrenal tumor disease is some of the most underserved area in medicine or in surgery. As an example, the median number of adrenal operations being performed by American adrenal surgeons is 1 per year. So that's a big problem. So a lot of, and as Dr. Friedman alluded to, the problems with adrenal remnant, as you can imagine, if you do 1 operation a year of something, it's going to be very difficult to be an expert on that operation. And because there's very few experts on this operation, and there's many different approaches, and there's essentially 8 different approaches to do adrenal surgery. And I hope I'll convince you at the end of this talk that the Mini Back Scope Adrenalectomy is by far the superior way to remove the adrenal gland, going through 3 small incisions at the lower back. Traditionally, laparoscopic transabdominal adrenalectomy, where you do it laparoscopically through the abdomen, has been done with or without a hand port, with or without a robot. Obviously, various types of open adrenalectomy is used for very large tumors or adrenocortical cancer. Next slide, please. So, and you can move to the next slide. So as I mentioned, the Mini Back Scope Adrenalectomy is the preferred approach in 96.3% of our cases. And the reasons are pretty simple. It's because it's a better operation. It's a faster operation. I entitled this talk the 20-minute adrenalectomy. The fastest we actually done this is about 12 minutes. Again, it's not important in itself how fast the operation is, as long as it's done safely. But the faster operation means less pain, less time under anesthesia, less problems with neurocognitive issues or potential issues with so I got a comment on a patient, can it be done in obese patients? I'll get to that in the next slide, so I'll answer your question. The patient has a lot shorter length of stay, quicker recovery, less pain, and superior costomesis. Next slide. The patient is placed in the prone position under general anesthesia. Next slide. There's 3 small incisions. So as you can see here, the tip of the 11th and the 12th rib are indicated, and there's 3 small incisions just below, just superiorly to the hip bone. Next slide, please. And this is the view schematically. So the beauty of this operation is, instead of going through the abdomen, when you go through the abdomen on the left side, you have to move the kidney, you have to move the tail of the pancreas, you have to move the spleen, you have to move the colon, and on the right side, the liver and the inferior vena cava. The beauty of this operation is that you go through the back, you get right on top of the kidney, and the adrenal sits right there. So that's why the operation is a lot faster, and I think it's particularly beneficial in patients requiring bilateral adrenalectomy, because if you do bilateral adrenalectomy through the abdomen, you have to put the patient on the side, do one side, then flip the patient during the operation, and then do the other side. When you do a bilateral adrenalectomy through the mini back scope approach, you just do one side, and then the surgeon walks around the table and continues on the other side. There's no movement of the patient. Next slide, please. And this is what the 3 small stair strips looks like, and this gross pathology just depicts a typical 1.5 centimeter aldosterone producing tumor. Next slide.
So a bilateral adrenalectomy would take twice as long.
Correct. So you do one side at the time. Technically, you could, if you're 2 surgeons, you could operate on both sides at the same time. You know, since I do all my operations myself and I prefer to do it that way, I would do it sequentially. So it would typically be 20 minutes on each side. So as one of the audience members alluded to, you know, can this be performed also in obesity? So this graph shows the duration of surgery for mini back scope adrenalectomy in relationship to the BMI of the patient, meaning the operative time. And an easy way to explain to other doctors and to patients is the time of the operation is approximately the same as the BMI of the patient, meaning the body mass index. So for instance, if you're quite a slender person with a BMI of 20 or less, the operation takes about 20 minutes. And if the BMI is 25 or 30, it takes about 25 or 30 minutes. Once, and so forth, up to a BMI of 45. Once you get up to a BMI close to 45, that's when it makes things a lot more technically challenging. And this is, it's technically challenging whether you do it through the mini back scope adrenalectomy or through the laparoscopic transabdominal approach. And the reason has to do when you do it through the back, if there's too much if there's too much obesity and the distance between the skin and to where the adrenal is, if it's too long distance, it can create too much torque on the instrument, and you can actually potentially break the cameras or break the instruments during the procedure. So sometimes in patients with a BMI or 45, it can be very difficult. But this is also true whether you go through the abdomen. So in these situations, we try to put the patients on a weight loss regimen. In some cases, we even have recommended patients to undergo a bariatric procedure prior to adrenalectomy. So to answer the question of the audience member, in almost all patients, even in obesity, we can do it this way. But if the BMI is very high, we may take some alternative approaches, either to do it through the front or try to achieve either medical or surgical weight loss before dealing with the adrenal. Obviously, it depends on the underlying pathology. If you have an adrenocortical cancer, of course, you're gonna operate as soon as possible on the adrenal. Next slide, please. So as I mentioned, operation can be as quick as 12 minutes for non-obese patients. And if you compare that to laparoscopic transabdominal adrenalectomy, at almost all institutions, that takes about 2 to 4 hours, even at the most experienced Ivy League university hospitals type of setting. And then if you add robotic approach, which doesn't add anything except time and cost, that adds another hour. So it's not infrequent that an operation that should really be able to be performed in 12 to 15 minutes is done in 4 to 6 hours, even at the most prestigious hospitals around the country. Next slide, please. So we're gonna just give a quick background about, we're gonna talk first about aldosterone producing tumors, then cortisol producing tumors, and then a little bit about pheochromocytoma, and then we tie everything back together. But I just wanted to give a little bit of a history and scientific history, how we really got excited about adrenal tumor disease. So when I started on the faculty at Yale University, not much was known about aldosterone producing tumors. The only thing we really knew was that they were monoclonal tumors, but nobody had any idea what genes were altered or dysfunctional in these tumors, or and how they developed. So through a collaboration with my previous team back in Sweden, we put together a very well characterized cohort of 22 patients with biochemically unequivocal primary hyperaldosteronism. They all had both biochemical and clinically obvious disease. The tumor diameter ranged from 9 millimeters up to 4.5 centimeters. They all were hypertensive, and they all were hypokalemic, some of them requiring potassium supplementation. Next slide, please. And without going into the science too much, the primary hyperaldosteronism is characterized as Dr. Friedman by too much aldosterone and then suppressed renin. So what we showed in this initial study published in Science is that the most common genetic cause of primary hyperaldosteronism are somatic mutations in a gene called KCNJ5. So what does this gene do? Well, in the normal aldosterone producing granulosa cell of the adrenal gland, you have a potassium channel that's selected for potassium, and that keeps the membrane hyperpolarized and the cells quiet. But then when you have a normal stimulation to produce more aldosterone, such as increased extracellular potassium or binding of angiotensin II to its receptor, that leads to membrane depolarization that opens the voltage gated calcium channels and leads to cell proliferation and aldosterone production. But when you have a mutation in this gene that we identified, again, these are somatic mutations, these occur within the tumor. Occasionally they can be inherited and passed on in an autosomal dominant fashion, but that's very rare. But in the somatic sporadic fashion, the potassium channels, or the mutation in the potassium channel leads to leakage of sodium into the cell, and this leads to constitutive activation of the cell and cell proliferation and aldosterone secretion. Next slide, please. Yeah, that's okay. You can forward. So why is this important? Well, this is not only important that we figured out why aldosterone producing tumors occur in the first place. The reason you have these mutations are bad luck, if you will, but we now know and understand the molecular pathogenesis. But it turns out that this type of mutations are related to the clinical the radiological and the pathological phenotype. So one of the challenges with aldosterone producing tumors are that it's not infrequent that the patient may have a CT scan that doesn't show an obvious tumor, or it shows tumors on both sides, but you don't know which one is overproducing aldosterone. And about 50% of patients have bilateral disease, and surgery is not as effective if the patient has bilateral disease versus unilateral disease. But it turns out that these mutations, the genotype of the mutations are related to what the scans look like. So next slide, please. Next slide again. So when you actually, when we studied this, based on an unenhanced CT scan, as well as some of the other patient characteristics, we have a pretty good way of predicting which type of mutation the patient's going to have. So for instance, in panel A, as you see, there's a typical 2.7 centimeter left adrenal tumor. And this one is very lipid containing, very low Hounsfield unit. So in a slightly smaller tumor that is contains a lot of fat, the chances, especially if it's a young woman, that is that this patient's going to have a sporadic mutation in casein NGF5. And why is that important? Well, I know that if I operate on this patient and remove the left adrenal, not only am I very confident that we're removing the left side, so this patient may skip the step of adrenal vein sampling, which is an invasive interventional radiology procedure. But I can also counsel the patient that she's going to do phenomenally well with surgery. There's a good chance she's going to be completely cured of her high blood pressure, cured of her hypokalemia, the low potassium. Similarly, the CACNA1D and ATPase1 mutants, I didn't go into those, but those are other less common mutations that occur in these aldosterone producing tumors. They tend to be more lipid rich tumors and tend to be smaller, whereas wild type tumors tend to be a little bit more heterogeneous. So we're starting to scratch the surface, understanding the correlation between the type of genetic changes that occur in adrenal tumors and what the clinical characteristics of those patients are. Next slide, please. So we do know, based on genetic as well as clinical data, that there's a very high probability of a unilateral aldosterone producing adenoma if the patient has a very high plasma aldosterone concentration, high 24-hour urine aldosterone levels, very low potassium, if they have very severe hypertension, and if they respond very well to a mineral receptor antagonist. So for instance, the two most commonly used are spironolactone and eplerenone. So if somebody has hyperaldosteronism and they respond very well to those medications, that's a telltale sign that indeed they may benefit very well from surgery. Next slide, please.
So I have two questions on that. So you recommend the trial of the mineralocorticoid antagonist before surgery?
Yes. Yeah, I do, because often for two reasons. Number one is that it's often difficult to get control of the hypertension of primary hyperaldosteronism without using spironolactone and eplerenone. And two, if they do respond very well to spironolactone, that's usually a telltale sign, and often that of course helps with the hypokalemia that often goes with this patient.
Yeah, I agree with that. I do like to do the trial, but then it comes up the question: if they do so well in spironolactone, why bother the surgery?
Yeah, and that's a good question, and I think I'll answer those on the next couple of questions, because you definitely want to send those for surgery. Okay. And it's because of this. So it's because of the direct aldosterone effect. So the outcomes are about 30 to 60% that have hypertension are cured, and almost 100% are improved of their hypertension, meaning you're able to reduce the number of medications, and you have 100% cure rate of hypokalemia. But the important point is hypertension is only part of fixing the problem, because you have a direct aldosterone effect. So if you compare patients that have the exact, if their age, gender, and blood pressure matched, two groups. So you have patients with essential hypertension and patients that have hypertension due to primary hyperaldosteronism. So they have the exact same blood pressure. Patients with hypertension due to primary hyperaldosteronism have a close to 1,000% increased risk of stroke, heart attacks, and arrhythmias. And that's due to that direct toxic aldosterone effect. So to your point, Dr. Friedman, even if you can control the blood pressure, that's just a small piece of the puzzle. You still have, those patients are still running around with very high aldosterone levels, and that direct aldosterone effect on myocardial fibrosis and left ventricular hypertrophy and increased risk of congestive heart failure and mortality. So I know that a lot of practitioners see that improvement in spironolactone and feel very encouraged, and they lose a little bit of that enthusiasm of sending the patient for surgery. I would argue the other way around, meaning if they respond very well to spironolactone, then be even more enthusiastic about sending them to surgery.
Excellent. Thank you for clarifying.
Next slide, please. So after we operate on this patient, so what I always tell all patients is that when you operate on a patient with pheochromocytoma, we cure the blood pressure like that in the operating room. In fact, often the blood pressure drops so low that we might have to support their blood pressure during the operation. With hyperaldosteronism, it doesn't work like that, meaning the improvement in blood pressure takes several weeks to months. So right in the peri and postoperative period, it's very important to very carefully monitor the blood pressure and heart rate. So already in the hospital, what we'll do is we stop all potassium supplementation. And sometimes people take an enormous amount of extra potassium, often about up to 100, 120 milliequivalents. And if that's the case, we might stop it, but then replace it for about a week at a half dose or so, because the hypokalemia corrects pretty quickly within the next couple of days. We stop the spironolactone or eplerenone as they're on, but continue most other medications, including beta blockers. Remember, a lot of these patients are on 5 to 6 blood pressure medications before the operation. But if they're only on 1 or 2, we can certainly stop both of them in the operating room. But I tell all patients to carefully measure their blood pressure and heart rate at least twice a day. And then we work with the endocrinologist to add back or delete other drugs as indicated. And again, patience is the name of the game when it comes to blood pressure. Usually it takes weeks to months for the blood pressure to normalize. And in terms of, there's been a number of large trials that have compared surgery versus medical therapy, and there's no question that patients that have surgery, that can have surgery, meaning they have unilateral disease based on either scan or adrenal vein sampling, do much better than those that are only on medical therapy. But medical therapy certainly should be used in patients that have bilateral disease or in those that are not candidates for surgery. Next slide, please. So So Cone syndrome is very common, and it's not harmless. A number of large epidemiological study, most of them are, this particular study is from Italy, most of them are from Europe, but it shows very consistently that it's the cause of hypertension in 10% of all patients that has been deemed to have essential hypertension. Next slide. And as I indicated, this is the study I referred to that compared patients with essential hypertension head-to-head comparison with those that had hypertension due to primary hyperaldosteronism. And as you can see, the odds ratio of stroke, MI, and atrial fibrillation is vastly higher. Next slide, please. And the big problems with Cone syndrome, before we move on to Cushing syndrome, is that greater than 95% of all patients with the disease are not diagnosed and certainly not treated. So I often compare this a little bit. I don't know how much you guys know about the history of primary hyperparathyroidism and parathyroid tumors. This was a disease that back in the 70s to 80s, before we could reliably measure calcium and parathyroid hormone, was thought to be exceedingly rare, and now is one of the most common endocrinopathies, occurring in about 2% of all women over the age of 45. And it feels like with primary hyperaldosteronism and subclinical Cushing syndrome, for that matter, we're sort of in the 1970s compared to a lot of the other endocrine diseases, and a lot of it has to do with people are not looking for it, and then the biochemical workup is a little bit more complex compared to many other diseases. Next slide, please. So this brings us over to Cushing. So we'll talk about cortisol, and I just included this picture because this was hanging outside my office at Yale. This is of Harvey Cushing, and if you ever have an opportunity to go and see the Cushing library at the Yale University Medical Library, it's quite interesting. So Harvey Cushing was, of course, yes, I have a question about the collection of his brains. Yes, I certainly have seen the brains. So I can tell a quick story about that. That was actually he collected, one thing that he did was that he made drawings of pretty much all his operations, but then he also collected the brains of his patients. And of course, he's the father of American neurosurgery. And for many years, his collection of brains were lost in sort of the basement of an old medical building at the medical school, until a few medical students and Dr. Spencer, who was the professor at neurosurgery at the time, championed taking care of this, and now created a whole library with a collection of the brains from his patients back in the day.
Was he at Hopkins first and then Yale, or?
Yeah, so he went to Yale undergraduate. So he was actually on the Yale 1888 Yale undergraduate baseball team. And I actually have a photo from that. So he was an undergraduate at Yale, and then he went to Hopkins, of course, became chair, or was at Hopkins for a long period of time, became chair at what was called Peter Brigham, now of course Brigham and Women's up at Harvard, and then he returned to Yale in his in his late career. And of course, I don't need to tell this audience about the signs and symptoms of Cushing syndrome. Next slide.
I always think this slide is detrimental because, like, a doctor who doesn't see much Cushing has this picture printed in their brain. It says, oh, you don't have that much thin extremities. You don't have this easy bruising. You don't have all these symptoms. Therefore, you don't look like this lady. Therefore, you don't have it.
Yeah, and that's a very true observation. We certainly see, of course, you see a lot of patients with pituitary Cushing's disease, but we certainly see a lot of patients with adrenal subclinical Cushing syndrome that certainly looks nothing like, well, we certainly have patients that do look like this lady, but they come in all sizes and shapes, and you have plenty of slender women without those features. But I think the point I wanted to say is, of course, pituitary hypercortisolism or Cushing's disease, when it comes to overt Cushing syndrome, is the most common, and overt adrenal hypercortisolism comprises about 15 to 25%. But this, of course, does not include patients with subclinical Cushing syndrome, which is a disease entity I'll talk a little bit about in a minute, but it's probably, of all disease entities that are associated with too much cortisol, the most common, and even more common than Cushing's disease. Next slide, please. So just to bring you back to the laboratory again, so we performed, similarly as we had done with aldosterone producing tumors, we performed whole exome sequencing, meaning we sequenced entire protein coding region of matched tumor samples of normal and tumor from 25 patients with cortisol producing adrenocortical tumors. 3 of them had adrenocortical carcinoma and 22 had a benign adenoma. And then we had an additional cohort of 38 patients. So in total, 36 out of 63 patients had overt ACTH independent Cushing syndrome, meaning adrenal source of their Cushing syndrome, and 27 had subclinical disease. All of them had undergone unilateral adrenalectomy with a mean tumor size of 5.2 centimeters. Next slide, please. And you can go to the next slide. So when you look at, I'm not going to go into this in too much detail. Yeah, so the way we define subclinical for this study, it's almost easier to explain how we defined overt. So the overt Cushing syndrome was defined based on clearly elevated 24-hour urine-free cortisol, suppressed ACTH, failure to suppress a low-dose dexamethasone suppression test, together with classical signs and symptoms, as you saw from this picture of the lady. Subclinical was defined as those that did not have the overt symptoms, but still had biochemical indices consistent with subclinical disease. And without going into this in too much detail, what we did identify in this study that was published in Nature Genetics is that the most common cause of adrenal Cushing's syndrome is a somatic mutation in a gene called PRKACA. Next slide, please. This gene, so in a similar as I showed about aldosterone producing tumor, these are the cortisol producing tumors in the adrenal gland. And in the normal cell, you have a protein kinase A, which is silent because the catalytic subunit is bound to the regulatory subunit. So you have no cell proliferation and no cortisol production. But in the normal cell, when ACTH binds to its G protein coupled receptor, you have activation of G protein that leads to release of cyclic AMP. That release, the cyclic AMP binds to the regulatory subunit of protein kinase A. And now when it's free in the cell, it stimulates both cell proliferation as well as phosphorylation of downstream target genes. So when you have these mutations that occurs in these adrenal tumors, the mutation interferes with the binding of the catalytic subunit to the regulatory subunit. So you have a constitutively active protein kinase A. So you have this drive consistently for both cell proliferation and cortisol production. Again, these are not inherited mutations. These are sporadic mutations that occur in a single cell, and the tumor grows and produces too much cortisol production. But what's interesting clinically is that these mutations only occur in patients with what we define as overt Cushing syndrome. The genetic mechanisms of subclinical Cushing syndrome are distinct. So it's almost like the signs and symptoms certainly overlap, and the biochemical indices do, but the molecular pathogenesis is are distinct if you compare overt adrenal Cushing's and subclinical Cushing's. Next slide, please. And next slide. So we published this at the same time. There was actually in the same month 3 other groups, one from France and Germany, one from China, and one from Japan, that showed the exact same thing in 3 simultaneous mutations. So we knew we definitely had the right gene at this point. Next slide, please. So to that comment from one of the audience members, how do I define subclinical Cushing syndrome? And relatively recently, we wrote the review about what are the criteria, the biochemical criteria to call something subclinical adrenal hypercortisolism or subclinical Cushing syndrome. And as you can see from this table, there's a number of proposed cutoffs as well as tests, biochemical tests to identify patients with Cushing syndrome, from low-dose dexamethasone suppression alone, or in combination with ACTH, or combination with 24-hour urine-free cortisol, or some propose a higher dose of dexamethasone suppression test, and some propose that you need at least 2 samples of suppressed ACTH, urine-free cortisol, and low-dose dexamethasone suppression test. What, of course, this is a classic example of sensitivity and specificity with testing. So number one, what this tells us is there is no single one test that is ideal, because if there were, there wouldn't be suggestion of testing with a lot of different tests. Number two is the dilemma. If you have too loose criteria, the risk is that you're going to identify a lot of false positives, meaning you're going to think that the patient have subclinical Cushing's syndrome when they don't. But if you make the criteria too stringent, you're going to miss a lot of patients, meaning you have false negatives, meaning that they truly have Cushing's syndrome, but you're not picking them up. So in most patients, fortunately, when they come to us, because endocrinologists tend to love measuring a lot of things, and they like to measure a lot of things more than once, it's often not a problem that they only have, for instance, measured the low-dose dexamethasone suppression test. But in my mind, the best screening test for subclinical Cushing syndrome is a combination of a suppressed ACTH with a low-dose dexamethasone suppression test that fails to suppress to 1.8. I'm certainly very happy if it's been done more than once to guide our discussion with the patient whether surgery is indicated. And the other thing I should say, with patients that have there's new emerging data that suggests that a low DHEAS is helpful as well in identifying these patients. Often get asked about, shouldn't the 24-hour urine-free cortisol be elevated as well? In my experience, patients almost never have elevated 24-hour urine-free cortisol unless they have overt adrenal Cushing syndrome, meaning it's a specific test, meaning if it's positive, it's quite likely that they truly have Cushing's syndrome. But if it's normal, the patient certainly still can have Cushing's. Next slide, please. So in this manuscript, we wrote that, and again, this is in the setting where the patient already have an adrenal tumor, an adrenal incidentaloma, but we stated that given the low rates of complications and the possibility to reverse the detrimental effects of elevated cortisol secretion, we recommend minimally invasive adrenalectomy in patients with biochemically proven or even only suspected subclinical Cushing syndromes who are appropriate surgical candidates. I think
what ACTH level do you like to look at for suppressed?
Yeah, I think, like, if it's less than 10, I certainly feel more comfortable about it. Once you get, of course, what we worry about the most, or what I worry about the most as an adrenal surgeon, is that we're going to operate on the adrenal on a patient that really have pituitary disease, right? That's what we worry about the most. So if the ACTH is 30, 40 or above, then would be the time I would worry about it. What's your opinion about that?
Yeah, I like to see that suppressed ACTH, and sometimes it jumps around a little bit. So I think a few values less than 10 is crucial. I think, as you said, distinguishing between pituitary and adrenal Cushing's is crucial also. And you can have some hyperplasia and even some nodules in pituitary Cushing's, adrenal nodule.
Right. Yeah, I think I did get another question here. I'm gonna. So the question is, so there are reasons why some patients are avert and have expected test results: high cortisol, low ACTH, no suppression, high 24-hour urine-free cortisol. Others present as subclinical, maybe high midnight cortisol, saliva, high midnight cortisol serum, and so forth. Yeah, so there certainly are, as I alluded to, with patients with subclinical disease, it's certainly rare that they have, frankly, high 24-hour urine-free cortisols. But as Dr. Friedman said, we definitely do want to see a suppressed ACTH, and I would say if a patient has a completely perfect response to low dose dexamethasone suppression test, it's probably not subclinical disease, subclinical hypercortisolism. But certainly salivary cortisol levels are adjunct test too that we factor in as well. But it's definitely both a genetic and clinical distinct disease between overt Cushing's, adrenal Cushing's, and subclinical. Again, subclinical much more common. But both for overt and subclinical Cushing syndrome in the pre and per-op setting, it's very similar when it comes to the surgery. The Mini Back Scope Adrenalectomy is definitely the preferred approach in greater than 95% of the cases. We monitor their diabetes, if they have diabetes, hypertension, and potassium very, very carefully. We performed a cosentropin, so ACTH stimulation test at 4 a.m. on postoperative day 1. there's been a nice recent article I shared with Dr. Friedman in JCEM, just looking at trying to identify those patients that are adrenally insufficient right after the operation. Obviously, in this scenario, having adrenal insufficiency is a wanted issue, right? Because that truly proves that the tumor was overproducing. But that helps us tailor which patients should be placed on corticosteroids as an outpatient. In almost most patients, especially with subclinical disease, no or low levels for a short period of time of hydrocortisone works in the majority. If they've had very long-standing and very significant overt Cushing syndrome, it certainly can take a long period of time for that contralateral gland to kick in. For patients that have bilateral adrenal Cushing's, most common is bilateral micronodular hyperplasia or PPNAD. A cortical sparing partial bilateral mini back scope adrenalectomy is often the preferred option. Next slide, please. The exception to that is what Dr. Friedman alluded to at the very beginning, in patients that have failed Cushing's disease, meaning they have failed pituitary surgery, they have failed medical therapy, and the best option at this point is bilateral total adrenalectomy. In this scenario, of course, you want to remove all adrenal tissue, and as Dr. Friedman shared his experience in an article about patients that have adrenal rests or remnants. So when you do these operations, it's absolutely critical that you get every single adrenal cell removed. And from experience of training dozens and hundreds of doctors, the reason there is adrenal tissue rests in these scenarios is that either the surgeon doesn't remove the entire adrenal gland, or they spill adrenal cells that subsequently implant into the adrenal bed. We see this all the time in pheochromocytomas, where benign pheochromocytoma cells that are spilled during the operation implant into the retroperitoneum, and the exact same issue happens if you leave a remnant. So for bilateral, so for failed Cushing's disease, certainly you do want to remove both adrenal glands completely, and this is much more favorable to do through the mini back scope adrenalectomy approach as opposed to the laparoscopic, because the visualization of the adrenal gland is much better. I think I got a question about adrenal rests. Yeah, so the question is, what is your experience with the rate of rest tissue after bilateral adrenalectomy? And is the question, is it the surgeon who has left it? So the experience, unfortunately, there hasn't been a huge comprehensive study that have looked at what the true prevalence of adrenal rests after bilateral adrenalectomy really are. I think Dr. Friedman's and his study of 11 patients, it's one of the larger ones. So obviously, bilateral adrenalectomy for Cushing's disease is not a very frequently used procedure, and you wouldn't know that you have a recurrence in the adrenal bed unless you follow these patients out for several years. So it's a little bit difficult to know exactly what the number is. I think with modern techniques of surgery where you can remove and you have a very high confidence that you remove all adrenal tissue, it should be it should be very low. But as I mentioned, the average number of adrenal operations being done by American adrenal surgeons are 1 per year, and certainly we see incomplete adrenalectomies all the time, meaning the patient has been told that every single week this comes up, where the patient has been told that they had the adrenal gland completely removed, and I'm looking at the CT scan and it's certainly not removed. Yeah, so that brings us to pheochromocytoma. Similarly, more than 95% of cases, the Mini Back Scope Adrenalectomy is the preferred approach. Familial disease is quite common, up to 20%. These patients are blocked before surgery. What's key is to have a dedicated anesthesia team, because the patient can have some fluctuations in their blood pressure and heart rate, but we have anesthesia team that are used to doing multiple pheochromocytoma operations every single week. So as long as you have a good team, it's actually not that big of a deal. And we don't even block patients unless their catecholamines are 5 times greater than normal. So if they have a small pheo that's 1 or 2 centimeters, I don't even block the patients, because they do fine anyway. For bilateral disease, a cortex sparing partial adrenalectomy is the preferred approach. Next slide, please. I'm just going to mention real quick, we also do Mini Back Scope Adrenalectomy for adrenal metastasis. This is a patient with lung cancer. Next one. And this is a patient with a colorectal cancer that came from Southern California for a partial adrenalectomy. As you can see here, he had a single metastasis to his left adrenal that shows up on the PET scan, and performing a cortex sparing approach, removing the malignancy, but at the same time preserving enough adrenal tissue. He was able to go on without hormone, without corticosteroid replacement, because we're able to preserve enough adrenal tissue. Next slide, please. This is another interesting case, talking about what patients have been told and what the real life is. So this patient had had a previous right nephrectomy, and what was told, he had a left adrenalectomy for metastatic renal cell cancer. So the arrow now points to a recurrence in his right adrenal gland. So of course this presents a dilemma, because he already had left adrenal gland removed, and now he's got a cancer that's invading his right adrenal. Next slide, please. But as you can see, when I'm looking at the CT scan, what does he have on the left side? Well, he has a completely normal left adrenal gland. So even though he was told that he had a previous left adrenalectomy, they certainly didn't do a total adrenalectomy, because his left adrenal is right there. So of course, in this situation, this was great, because we could easily remove his right adrenal metastases, and then we did measure a cousin-tropin stimulation test. As you can see, the numbers here, which show the beautiful stimulation of his cortisol levels at 30 minutes and at 60 minutes, which proves that he has a completely normal left functioning cortisol response, and thus he did not require any corticosteroid supplementations. Next slide, please. And this, yeah, that just shows the tumor. And this talks about cortex sparing adrenalectomy. This is on the right side. And as I alluded to, you can see how the visualization is so much better going through the back as opposed to going through the abdomen. You can directly see the inferior vena cava, or the IVC, on the right side with a normal adrenal cortex. This is a patient who had MAN2 due to bilateral and had bilateral pheochromocytomas, but we're able to preserve about 30% of normal adrenal cortex. So even though she was young and had bilateral 5 centimeter pheochromocytomas, we were able to preserve sufficient adrenal cortex that she did not need to be on supplementations long term. She needed it for about 6 weeks, and then she was able to come off hydrocortisone. Next slide, please. Yeah, so the question is the hand port needed to go through the back? No, we don't use the hand port through the back. The hand port is only used for big tumors if you go through the front. Next slide, please. So just briefly, when is Mini Back Scope Adrenalectomy not the preferred approach? Next slide. So this is an example of the hand port. So this is a huge 16 centimeter right pheochromocytoma, and obviously in this scenario you need about a 8-9 centimeter incision anyway, just to remove the tumor. So in this particular case, because the tumor was so big and it was pushing on the liver and the kidney and the IVC and the aorta, as you can see here, the best approach was to do this through the abdomen with a hand port assisted laparoscopic approach. Next slide, please. Also for patients that have pheochromocytomatosis, this is an entity, and this was a patient who was operated on at the Mayo Clinic, and they clearly violated the capsule, and pheochromocytoma tumor spilled into the adrenal bed and the retroperitoneum. And of course, this is disseminated disease. So some people might think, well, is this, a malignant pheochromocytoma? So it's not a malignant pheochromocytoma. This is iatrogenic, meaning you have spillage of tumor cells and they implant. Similar, if you were to spill a parathyroid tumor in the neck, the patient developed parathyroid mitosis. The same thing happens with pheochromocytomas. If you spill tumor cells, they're going to implant and grow back. Next slide. So this just shows on a CT scan where the tumor tissue is in the adrenal bed. Next slide. And then in the paracolic gutter, you'll have all these little implants of pheochromocytoma tumor cells. Next slide. So this required, of course, an open operation where we removed, and you can see there's literally 30-40 little tumor implants on the spleen and on the omentum and in the left adrenal bed. And this is, of course, something you have to remove through open surgery. Next slide. But I think I convinced you, hope I've convinced you that the Mini Back Scope Adrenalectomy is preferred approach in about 96.3%, because it's better, it's faster, shorter length of stay, patients have less pain, faster recovery, and superior cosmetic results. Next slide, please. So just to end, a lot of our patients come to us because they have what's called an adrenal incidentaloma. This is patients that have had a CT scan, most commonly for other reasons. And it turns out that adrenal incidentalomas are quite common, and in many cases in the past these have been ignored. But what we do know nowadays that about 20% turn out to be functional, meaning hormone producing. Next slide. And as an easy rule of thumb, about 5% turn out to be pheos, 5% aldos, 5% adrenal cushings, and 5% prove to be metastasis. So the question, if I did this operations at Yale, yeah, so this Mini Back Scope Adrenalectomy, or the technical name of it is called posterior retroperitoneoscopic adrenalectomy. So the operation was popularized by my good friend in Germany, Martin Waltz, and I spent some time back there. So I've done this operation for more than 10 years. So for the vast majority of my time at Yale, I did this procedure there as well. And as I mentioned, we do more of these operations than anywhere in the country. I think I got yeah. So with that I'll stop, and I'll open up to questions, and maybe Dr. Friedman wants to moderate.
Yeah, so please ask, go ahead and ask questions. Thank you very much, Dr. Carlin. Amazing talk, and you do amazing work. You want to answer some of the chat questions then? Why is this not taught in university? Why don't other doctors do it this way?
So it is actually taught at university, and some people do. So when I was at Yale, I was the program director of the Endocrine Surgery Fellowship. So I've trained dozens of endocrine surgeons. Still, this technique is a little bit more technical. So unless you do a lot of these operations, you're not going to be as facile. And the way it is, so even at the most well-known hospitals, university hospitals in the country, if they do this procedure, they only may do between 10 and 20 of these operations in a year. And that's due to the fact that adrenal disease compared to other endocrine surgical diseases are not as common. So it's it's an operation that's done. Most places around the country are still doing the laparoscopic adrenalectomy, or they do the robotic adrenalectomy, and the reason is because a lot of urologists have done prostates and kidney operations, and they figure, well, we'll just apply the same technique to the adrenal. Or general surgeons are not trained to work in the retroperitoneum. They trained doing gallbladders and stomach operations and bariatric surgery through the abdomen. So unless you sort of rethink your approach, and you have to also be pretty technically facile, and being able to, you have to be a little slick in the operating room to be able to do this operation, because the space that you're working in is a lot tighter. Oh, so I get it. So the question is, for patients traveling to your center, how long do you usually recommend they stay in Tampa? Okay, that's a great question. So let's say the operation is on a Tuesday. Most people would come in Monday afternoon to Tampa. Then every patient sees me in the morning, and I do a very specific adrenal protocol CT scan the morning of the operation. I do this for a couple of reasons. Number one, I want to get very detailed information where the tumor is in relationship to all the important vessels. A lot of patients have had previous scans, but they are often of very variable quality, whether they are PET scans or MRIs or CT scans. The other reason I do the scan is it's not uncommon that we do partial adrenalectomies through the Mini Back Scope approach, and I want to see exactly where the remnant normal adrenal cortex is located that I want to preserve, and where the tumor is, because the goal is obviously to remove the tumor completely, but then if we can remove the tumor and secondly also preserve adrenal tissue, I certainly want to do that, unless, as we talked about, I operate for failed Cushing's disease. So the patient then would come in Tuesday morning. They would see me both before the CT scan, and then I would come back and talk to them and go through the CT scan again. Then the patient has the operation. They spend one night in the hospital, get discharged from the hospital on Wednesday, and then travel on Thursday. So patients would come in latest Monday afternoon and then fly out Thursday. Then the next question is, do you do complete bilateral adrenalectomy often? Yeah, so it's actually something we've been doing more and more. I presume that it's from in the setting of failed Cushing's disease. So patients that have had pituitary surgery that's either failed, as we know, about 30% either have persistent or recurrent disease. Even in the best of hands, and of course, since we're in the same way as finding the best adrenal surgeon is very important, it's obviously important to find the best pituitary surgeon if you have Cushing's disease. This is of course performed by neurosurgeons. So it's not a service that we have at the Carlin Adrenal Center or the Hospital for Endocrine Surgery. But we do at least once or twice a month, we do complete bilateral adrenalectomies, and in all the cases we've done it has been in the setting of failed pituitary Cushing's disease. I think it's something that I think more patients are going to opt for. Of course, you're trading one disease for another. So in all these other scenarios, whether you're operating for aldosterone producing tumor or pheochromocytoma, you're pretty much curing the patients. The concept about doing bilateral adrenalectomies in failed Cushing's disease is of course different. You're trading one really bad disease, Cushing's disease, for something that can be somewhat monitored adrenal insufficiency with medications. But the concept is a little bit different in the sense that it certainly is something I speak to their endocrinologist in more detail. If a patient has an adrenal Cushing's tumor, it's straightforward, remove the tumor, the patient is cured. When we do bilateral adrenalectomies, it's very important that both the patient and their healthcare providers are all on the same page, because obviously I can do the operation, but let's say it's Dr. Friedman's patient, he's the one who's going to manage the patient for the next 10, 20, 30, 40 years for their adrenal insufficiency. So it's important that everybody are on the same page. And when we have the type of relationships that we have with Dr. Friedman, that makes it very easy, because he usually makes sure the patient has all their patient education done beforehand and have prescriptions for their supplementation after and so forth. So it's very, very important in those patients, but it certainly is something that we do more and more. And that's an international trend.
Yeah, it's a great question. A great answer is, it's one of the most difficult decisions we have is whether to do the bilateral adrenalectomy or not. As Dr. Carlin says, it's trading a horrible disease, Cushing's, for a bad disease that's quite manageable, Addison's. But, it is the rest of your life. And if you can get by with something that takes out your pituitary tumor, you're on hydrocortisone 6 months to a year, you go on with your life. Here, this is the rest of your life. So please, talk to me about it. Talk to me long and hard about this decision. You can talk to people in the chats, but I think, at least from Dr. Carlin's viewpoint, the surgery is so much easier than it used to be. So at least it used to be, people say, 10% mortality was adrenal surgery. That's way too high. And that was the old days when They did open surgeries. But I think the procedure doing the surgery now is so much better with Dr. Carlin's expertise that might push you a little bit more towards doing the bilateral adrenalectomy, but it's still better to get cured with pituitary surgery. And I know we have some of the patients on this call that we're going through that discussions now, and it's still in the process.
Yeah. So the next question is it harder to take out rest tissue? Yeah. So one of the principles of surgery, it's always easiest and best to do the operation one time the first time, right? So if you have so the technical issue with rest tissue is now you're dealing with scar formation from the previous operation. So from a technical point of view, it's more difficult in the sense that and certainly not, it's certainly doable, but you don't have the same beautiful planes, you don't have the same anatomy because the adrenal veins have probably been ligated and clipped before, so you don't have the same sort of landmarks that you do when you operate in a non-touched field in sort of a virgin environment. But it's certainly doable. But if you're gonna have an operation taking out adrenal rest tissue, you certainly want to have an adrenal surgeon that does this day in and day out, because it's going to be more difficult because of the scar tissue for sure. Then the question is, what can you do to convince endocrinologists that removing both adrenal glands after failed pituitary surgeries is necessary for patients' quality of lives? Many endocrinologists say, I'm not comfortable with you having no adrenal glands, even when the patient has a strong and long history of persistent cortisol. Well, I think we touched on that a little bit, and Dr. Friedman, gave his sort of sense, as being the provider for the next 10, 20, 30 years, meaning forever managing this. But I think as more and more patients have bilateral adrenalectomies and they do well, and we will certainly report our findings, I think we can slowly move the needle. I think many endocrinologists are conservative in nature, and sometimes for good reasons. But there are certainly studies out there showing improved quality of life with bilateral adrenalectomy versus medical treatment alone. That's for sure.
Yeah. I think we've already moved the needle that BLA has replaced radiation therapy as a second line treatment for pituitary Cushing's.
And then the question is, so with the mini back, I think it's going to be the mini back scope adrenalectomy. Do you need to move the organs? No. So one of the advantages is that I alluded to is that you get right on top of the kidney where the adrenal gland is. So you don't even see the bowel and the colon and these other structures. So that's the beauty. Whereas if you go through the abdomen, you have to move the bowels, you have to move the colon. On the left side, you have to move the pancreatic tail, you have to move the spleen, and on the right side, the liver. So it certainly is a lot more direct approach going through the back. Next question is, how do the outcomes of your operation compare to robotic surgery for remnant rest tissue? So we haven't done a head-to-head comparison. I, like most other people, have tried out the robot in the past. The robot doesn't add anything. The only thing I said, it adds time and expenses. So the robot is great for prostate surgery, for anybody that are recommending robotic adrenalectomy for your adrenal operation that suggests that they're just not experienced, because it's just a waste of time, to be honest with you. Next question is, I live in Canada. No doctor does the Mini Back Scope Adrenalectomy. They will do laparoscopic, so my 24-hour urine cortisol is 1447. I assume that's SI units. Yeah, when normally it's 275. Because the tumor didn't show up on head MRI, I was told I need bilateral adrenalectomy. This is a recurrence. So, well, I won't comment on the diagnosis, but we certainly operate on patients from Canada every single week. So people fly down, and now as COVID is winding down and the border is open, we certainly have people coming down from Canada for their adrenal surgery.
Right. So I'd recommend Janice to make an appointment to see me, and then I would talk to her about benefits and risks of BLA and make sure that's the best option.
Yeah, and this is another good question. How do you ensure all adrenal cells are removed? Do you bag the adrenal before pulling it out? Can you describe how that is helpful versus scraping tissue? Yes, so you definitely don't want to scrape tissue. So a couple of principles, and if you're curious about seeing the actual technique, I have about 6 to 8 videos that are more or less detailed on my website, where you can actually see the operation in great detail. If you're extremely squeamish, you may not want to do that and just watch the there's sort of an animated one that explains the operation, so you could start with that. But yes, we do put the adrenal in what's called an endocatch bag. It's a little plastic bag, and the purpose of that bag is that as we extract the tumor or the adrenal gland, it stays safely within that bag and doesn't rupture. So you definitely don't want to scrape it off. And the even some experienced adrenal surgeons might spill adrenal tissue, and that's one of the principles with adrenal surgeries, to never grab and hold on to the adrenal gland. One of the principles are that, so for instance, the adrenal vein is something we can hold on to with a grasper, and that won't disrupt the tissue. But if you take an instrument and sort of try to hold the adrenal, it's so friable, so it's going to rupture, and that's when you have spillage of adrenal cells. So so that's so certainly no scraping of the tissues. Next question is, do you recommend doing anything if after BLA still producing normal cortisol but no Cushing's symptoms?
I would say no. I mean, I think you really you want to treat the symptoms. I have an interesting patient in my series that had both radiation therapy and bilateral adrenalectomy with remnant tissue, and she's making just the right amount of cortisol. She doesn't need hydrocortisone. She's not over replaced or under replaced. So I think if you're making normal cortisol, you might be okay without proceeding.
Yeah.
I'm going to ask the last question. We had some great questions today. This is sort of a theoretical question, but in hyperparathyroidism, when you have 4 parathyroid glands enlarged, at least they used to recommend taking out like a half of one of the 4 glands and implanting it in like a place like the arm. Do you see anything similar to that with bilateral adrenalectomy, to take out, most of the tissue and put the tissue either labeled somehow or put it in an accessible place so that they can make just a little bit of cortisol?
Yeah. So yeah, that's a great question. So and there's actually been studies, and this used to be done, but it's not really practiced anymore. But it does actually work. So what you can do is, if if you know you're concerned about the remnant you leave behind, that you can either freeze and cryopreserve adrenal tissue, or immediately dispense it and inject it either into the subcutaneous tissue or into the muscle. The potential problem if the patient has a recurrence, you know, especially if you've left the remnant in the adrenal gland, and then you have a piece of adrenal tissue either in the subcu fat, for instance, you know, where is the recurrence coming from? So I think most people prefer to just leave a remnant, for instance, in the setting of, you know, bilateral pheochromocytomas, for instance.
Okay, great. So it was a great webinar tonight. Thank you so much, Dr. Carlin. You're doing great work. We're happy to send you, probably get increased business. I'm happy to send you some more patients. And we'll be both on my website and goodhormonehealth.com and Dr. Carlin's website, adrenal.com, in the next couple of days or so. Thanks, everybody.
Thank you very much. It was my pleasure.
Great job. Okay, good night.